Before we go to the rebuttals, if there are clarifying questions on the data specifically, if there are any, then Jose and Andrew can answer them. If not, we'll go to the rebuttals. We have Charlie, microphone 1, please.
So first of all, I would like to thank Andrew Hill for validating my habit of drinking Diet Coke with my donuts and biscuits. But I would like to ask you, Andrew, you implied that with integrase inhibitors, well, with dolutegravir and bictegravir, that you gain weight and you continue to gain weight as long as you take them. But does the data support that, or does the data suggest that you gain weight and then you plateau?
I think it depends on which cohort you look at. If you look at NA Accord, the body weight keeps rising, and that's the biggest cohort I've seen. But if you look at the NITO 22, that's mainly males, and mainly given with TDF, then there is a plateau. So I think there is a debate about that, but the biggest cohort is showing progressive rises over time.
Thank you. More questions? Clarifying questions? Again, microphone 1, please.
This is to Jose. If you were to choose the ideal 2 APIs or 2 classes, what would they be?
Well, I think from the virologic point of view, what we've learned after many attempts of using just 2 drugs is that you need a reverse transcriptase inhibitor. You know, all the trials, once and again, that haven't used a reverse transcriptase inhibitor have failed to match the efficacy of triple therapy. So the combinations that have succeeded has been a boosted PI plus 3TC. We don't tend to use a lot of boosted PIs, so that's one of the reasons not a lot use. Dolutegravir and rilpivirine, despite the adverse events that might happen, work, and also dolutegravir and 3TC. And still, I think it's fair. I've been talking about that a lot. That we still don't know the intimate reason why having a reverse transcriptase inhibitor is that important. There are biological reasons, might be penetrance also in some tissues, but I will always include a reverse transcriptase inhibitor.
Great. Well, if there are no others, we will go to the rebuttals. Jose, you want to take a few minutes?
Andrew, that was a great presentation. It was very funny, although you started with a very complicated theme. You know, in my experience, really, trios last less than couples. Common sense. So, I agree with many of the things that Andrew said, but Andrew focused really on particular drugs, and I think that's not that relevant for the debate. I understand that drugs have adverse events regardless if they are in dual or in triple therapy. You know, he talked a lot about dolutegravir and rilpivirine. Might be not the perfect combination, but dolutegravir and rilpivirine, their toxicity does not go away when you give them in triple therapy. So to me, if I have to pinpoint the question is, and to be, for example, specific, if you have now, you start a patient and is suppressed on TDF, FTC, dolutegravir, 20 years from now, he will be better off by continuing this triple drug regimen or by continuing only dolutegravir and 3TC and not using tenofovir. So I agree also with the other comments about you have to do more testing. It's true. If you work in a place with a lot of hepatitis B, all those comments are true. But there are different types of questions. And for me, where I practice, for me it's a relevant question to think about the long-term effects of other drugs. And it's true that until now, it might be that with long-acting and with these combinations, we will have more people treated with 2 drugs, and we will be able, for the first time in HIV therapy, and this is outside from clinical trials, because clinical trials capture toxicity in 2 or 3 years, but we still don't know what are the long-term effects of other nucleosides after many years. So I think that's an important issue. And again, my question will be that, is if you are using a particular drug in this combination TDF, FTC, dolutegravir, you will be better off by dropping the TDF or not. And I think we don't have a lot of data about that. He made, very good comments about discontinuations due to adverse events early on, but again, this is short-term. There were many adverse events that we didn't pick in short-term clinical trials, and I think that will not be solved until we have enough people treated with 2 drugs to be able, in cohorts, long-term cohort, to distinguish this type of long-term adverse events. And the other issue is about weight. I didn't give too much weight to that thing, but I'm quite confused, and I would like to see your opinion, because when we went back from CROI, we still don't know the fundamental question: is this weight gain bad or good? I understand. No, I didn't see the cohorts really doing a very good job at telling how much % of body weight they gain, if this is just return to health or not. And it seems from what you have said that TDF, apart from being lipid lowering, is also a weight control drug that you have to give to protect from the increase of weight with integrase inhibitors. I think it is something that we have to pay a lot of attention, but it's still, I don't know what we're dealing here with the increase in body weight with when you take, is TDF, how is the mechanism, is doing something good because avoiding this weight gain? I'm still quite confused. Those will be my main things. Okay.
Great, thank you, Jose. So we will now have the, so let's give Andrew also 4. That was, we'll just be very meticulous. Wonderful. So Andrew, your rebuttal.
So I think we've got to remember that we're treating over 20 million people, and we've got decades of research supporting triple combination therapy. And to start playing around with that, to start saying, well, let's just switch to dual therapy based on a few highly selective clinical trials in North America and Europe, is taking a big risk, and it's all about risk versus benefit. Now, if there was a great safety benefit to this dual therapy, if we had fewer bone fractures, fewer renal failures, something, but we haven't got it. And in the Gemini and Sword studies, there's nothing there. And unless you start scratching around, looking at these esoteric markers of bone turnover that nobody really understands the clinical significance of. I'm sure the companies want to say they're important, but nobody can really link them to any solid clinical outcomes. So I think if the safety is the same or worse for these treatments, and we've got decades of experience supporting triple therapy, what is the point of starting to play around with this, especially since there aren't even plans for looking at these dual therapies in a wider context in low-income countries, in people who don't have prior resistance testing, prior baseline viral load. If you start recommending these too widely, people could just use them in an uncontrolled way without the right diagnostic testing as background. Tenofovir has turned up surprisingly safe in the meta-analyses. Nobody's complaining about TDF-FTC as PrEP in the UK. People are using it in very large numbers, and it's not turning up with more adverse events in the big meta-analyses that we've conducted. We've got to remember that the program for all the dual therapies is incomplete. It just doesn't include long-term follow-up. And the elephant in the room literally is body weight. And if we've got signals, we've got a whole session at CROI on increases in body weight, and the 2 major studies of dual therapy, Sword and Gemini, didn't measure it, then I think that's not good enough. I think we have to have independent evidence that these drugs either are or are not causing significant body weight. I'm not talking about just a few kilos. I'm talking about progression to clinical obesity in a large number of people. I'm talking about progressive weight rises, significant weight rises that don't slow down over time. If we see that, then I think dual therapy is absolutely off the table. I think it should just be warned against. There should be a safety warning against it. And we simply don't know. But I think the evidence is suggesting that without TDF, the body weight rises on either bictegravir or dolutegravir are progressive, and it's not clear what we do with them. So thank you very much.
Great, thank you very much. So we'll open it up now for opinions on the topic. And David Beck here, microphone 2. We'll start it off.
Thanks very much. Andrew's a very good friend, but I think he's got two arguments that I would find difficult. One is the decades of experience. We had decades of experience of rifampicin 600, but we had a wonderful talk this morning from Kelly Dooley that, we probably need to change. That's far from being optimal. So I think the decades of experience argument is, you could put some holes into that from a number of therapeutic areas and probably also with this area. And I just wonder with the weight gain argument as well as a second issue, I think you advocated that TDF was counterbalancing the effects of dolutegravir and bictegravir. That was the only argument that you were really holding for the 3 versus 2 was the TDF. Was that in terms of the counterbalancing effect of the weight gain? Because otherwise, clearly, all the guidelines are giving us triples with bictegravir, dolutegravir, etc. So I'm struggling a little bit with your argument.
Yeah, I think with all due respect to the guidelines, they're being written in a data vacuum because the weight data isn't available. But I think what's emerging now is that if you give an integrase inhibitor without TDF, that the weight rises are going to be larger. And that's being seen, as I said, it's been seen, the effect of TDF suppressing weight gain has been seen in AMBER, EMERALD, DISCOVER, the PrEP studies. And I just think that information hasn't yet been filtered into the guidelines, unfortunately. And I agree with you about, decades of experience, but, that doesn't necessarily give us the right answer. But what about the flip side of that is going blind into giving people dual therapy if perhaps they did have Hep B co-infection but it hadn't been tested for, or they do have a history of virological failure but it wasn't known about. Actually venturing outside the realm of these highly selective clinical trials and just extrapolating that everything will be okay when I just don't know that it will. So I think the decades of experience in cohort studies are simply not there for dual therapy.
Microphone 2, Andrea.
They were great talks. I don't agree 100% on the safety of TDF with unboosted drugs. I read your meta-analysis. I think it's very well done. But still, there are data on urine biomarkers and on DEXA studies in PrEP that suggest that even unboosted, or even without the third drug, there's some damage. There's subclinical damage. We may argue there's a clinical meaning on the long term. But still, having urine biomarkers of bone and renal damage higher than the other arms is something I don't like. I wouldn't like to have it.
Yeah, I think that those studies have shown statistically significant differences in biomarkers, but whether the differences are actually great enough to have any effect on clinical outcome is debatable. There are no, in 25,000 patient years of follow-up on PrEP, there's been no increased risk of bone fractures, no increased risk of high-level creatinine elevation. So, sure, you could look at lipids. You could say there's a significantly worse lipid profile for TAF. It's significantly better for TDF. Does it mean anything? I don't know. I think we've got to be careful distinguishing statistical significance with actual clinical outcome. So you could have statistical effects that mean nothing at all.
Yes, but just as a follow-up. The first one is about RBP, for example, retinol-binding protein or albumin in urines. They're higher, and they're being linked to reduced bone mineral density in all cohorts. And again, you talk about selected population, but people using PrEP are usually male, and they're usually in their 30s. So that's a super selected population.
Other questions, other comments, other opinions? Microphone 1, please.
This is back to Jose. While I am enchanted by two-drug therapy, I wanted to correct something, at least for resource-limited settings. Although you may save $5 to $8 per patient per year, given the infrastructure and the testing that Andrew talked about, the cost of care, total care, goes up by about $100 per year.
Right.
So there is no holistic advantage cost-wise to going to a two-drug therapy.
Right now, yeah, I agree. I'm not disputing that. My comments about saving resources would be in the where I practice, in Europe or in resource-rich countries. But I understand that in those type of situations, the overall cost might be increased. Yeah.
So we're about 1 minute. One more comment here. Let's have a last comment from say microphone 2. Or question. We have 2 more minutes. Say.
So it was a question about cost again. So none of you talked about the legacy of a 2-drug regimen versus generic 3-drug regimens, and I think ultimately that's going to impact my practice if the differences are marginal. A 3-drug regimen, which is generic, is going to be much cheaper.
I agree.
Wonderful. So we're right on time. Before we close, I do want to. I think both of the talks were fantastic. I think both did a great job. I smell roadshow. I mean, I can see this. London, Los Angeles, Sydney. This will go global. So thank you both of you, and we'll move to the next session.